Hello everyone. Thank you for joining me today for the Spotlight on Safeguarding. My name is Hayley Jones and I'm Director of Homeless Services at YMCA Liverpool and Sefton. We are a key provider of supported accommodation in the city who are homeless or at risk of homelessness. Our homeless provision includes 3 hostels and dispersed accommodation across the city, and we currently have around 200 people living in our homeless services. As well as our homeless services, we also have other supported accommodation and other community services across Liverpool and Sefton. These include refuges for clients fleeing domestic violence, crisis and step down accommodation for those receiving support with their mental health, support for drug and alcohol with our RISE recovery service. We also have children and young persons services and a farm in South Liverpool that our service users can access to provide meaningful activity. So just to give you a bit of insight into who we work with and the support we provide, we accept referrals from clients with all levels of support needs. This includes accommodating those who have a long history of rough sleeping, multiple complex needs, and understandably a mistrust of services and non-engagement. Every individual housed with us receives support that is delivered in a psychologically informed environment, which provides the best possible opportunities for change and allows for an approach that is therapeutic and trauma-informed. We're actually only a temporary accommodation provider. Our contracted length of stay in our homeless services is 6 months, but due to the nature of our client needs and our person-centred approach, we actually have some clients for around a couple of years. Clients living with us have an allocated support worker. We're contracted to provide support and not care, but I have to say every one of our teams goes above and beyond their job role in the level of support they provide. Because our clients' needs are, and there's often a reluctance to access services, we also have a number of partners that provide in-reach services. So we have partners working in our building from Brownlow Health, drug services, a skin clinic. We offer medication storage and observed methadone consumption. And our staff deliver harm reduction and needle exchange programme. So just to tell you a bit about today's presentation, I'm going to talk today about a few safeguarding areas, not from a safeguarding expert point of view, but from a service provider point of view. And I'm hoping to highlight some recurring themes for our service, some challenges, but also some good practice we have embedded that might be of interest to similar services. So I think you'll be muted throughout the presentation, but there will be plenty of opportunity to ask questions at the end. So I'm going to start by sharing a client story which has been anonymised. This is quite a recent client we had in service that the teams had safeguarding concerns for. And later in my presentation, I'll refer back to Michael's journey, particularly in relation to reoccurring themes and challenges. So Michael came to us in April last year as homeless from another supported accommodation service that closed down. Michael had a history of offences, assault and theft, mainly shoplifting. Michael had a history of mental health and had been diagnosed with schizophrenia. He had a CPN who he actually engaged well with, and he was medicated with monthly depot injections. Michael's mum and social worker supported him to manage his money. So as Michael settled into the accommodation, we became more aware of Michael's needs and some areas of concern for him. Michael struggled socially, sadly often forming unhealthy friendships with others. We became aware that Michael would at times use crack cocaine, mainly payday. Michael would sometimes stay out of the hostel at times with friends that we did not know and could be difficult for the staff to locate. Michael would regularly refuse support around his personal hygiene and maintaining his living space. We would often be concerned around deteriorating health and safety of his living space. Over time, staff began to have concerns about Michael being targeted from other residents. So staff raised a safeguarding concern and reported this to Careline. Staff also discussed with Michael's social worker, letting him know our concerns. We also involved Michael. We asked him what could we do. Did he want to move accommodation? Did he want to move rooms? With Michael's involvement, he decided he wanted to stay, but to move rooms within the building away from other residents who were of a concern. Unfortunately, at this time, Michael's CPN was changed and staff tried to support him to engage with his new CPN and just be supportive in any way possible to help him engage with services. But Michael stopped engaging with mental health services and refusing the depot medication that he'd actually always been really happy to have administered. Engagement for our own teams became more challenging. Michael's self-care dipped further. He stopped maintaining his room. When staff offered support, they'd sometimes be met with verbal aggression. Michael was then discharged by his mental health team for non-engagement and missing appointments. As he had built some trust with our staff, he did acknowledge to our team that he was unwell, and he actually reported hearing voices. But he was saying he wanted to get better, and at this point we knew that there was possibly a window of opportunity to get him to engage, to explore options for his future well-being. He also stated that he didn't want to have depot injections. Around this time, we also received a call from the social worker informing us that the psychiatrist that had been involved in the case would not accept Michael back into their services without a re-referral through the GP. The GP, who was a family GP, not a GP that we work with often, asked firstly that he access drug services and that his primary concern was drug use and not mental ill health. But my staff team felt quite strongly about this and continued to look into their concerns, from pursuing advice from professionals at an MDT that we're involved with, where we were signposted back to Careline, but with some real clear advice on what to ask for from the safeguarding teams. So an urgent mental health assessment was organised by Careline, in which the outcome resulted that Michael was indeed at crisis point and needed to be hospitalised. With the support from our staff, Michael was willingly admitted by ambulance to a mental health inpatient hospital in August this year. Working alongside the team at the ward, we continued to keep updated on Michael's progress, and it was decided that it was not appropriate for him to return to homeless services, but would continue to stay in hospital and receive ongoing support and a care plan. We were really pleased and relieved, and it's strange really because as the way our system records, this would have looked like a negative outcome for us, but we were actually really made up to get Michael into the safe care of mental health professionals. So if we come back to areas of Michael's story and the rest of the presentation, next I wanted to just look at and highlight some reoccurring themes for our services around safeguarding. So it's sadly a regular occurrence that our teams become concerned that a resident is neglecting their self-care to the extent of concerns for health and safety of the client, like in Michael's story. And this can often be the first sign that there's something more underlying, there's more underlying needs or a deterioration in mental health or well-being. We, as an organisation, have always kept a record of our safeguarding cases, but we've actually been interrogating the data from our safeguarding reports more formally since around 2018. And you can see the graph on screen showing safeguarding concerns by abuse. 33% of our cases in our service have been logged as self-neglect. The other category is predominantly concerns around mental health dips, self-harm, disclosures of suicide ideation. And other reoccurring themes for our services include that our staff tend to lean towards a safeguarding inquiry over a social care assessment. Financial abuse concerns are often blurred with the codependency and relationships that occur in homeless communities. We have a lot of concerns linked to fluctuating capacity from substance misuse, misuse of medication, and entrenched addiction, and that is a regular occurrence for us. The next thing I really wanted to highlight was our challenges and sometimes frustrations. So dual diagnosis, the combination of substance misuse and mental health concerns, causes a challenge in getting support from additional services for our clients, but also, like in Michael's story, can cause a difference of opinion. Our clients generally have capacity to make bad decisions, but this can impact safeguarding teams' decisions, meaning that our clients don't always meet the threshold for cases to be accepted. So empowering our staff to be able to evidence fluctuating capacity is really important. Staff aren't always aware of the legislation and the thresholds that kind of underpins safeguarding inquiries and social care assessments. So there are challenges around them being able to appropriately evidence to meet the thresholds. Some external support agencies and services don't understand the level of support we provide. So as mentioned at the beginning, we are not a long-term accommodation placement and we're not a care provider. There are also possibly some gaps in services, and perhaps external services do think we are the best fit for the client's needs at the referral point. But we often realise quite quickly that we're unable to provide the appropriate support for that client to live a quality or standard of life that everyone should be entitled to. And understandably, clients' mistrust of services from past trauma leads to challenges with engagement, like in Michael's story. And then external services will often close our clients down due to missed appointments and non-engagement. So good practice. What have we got going on in our services to help with some of these challenges? And maybe if you have similar services, there might be some useful ideas. So definitely record your cases more formally. So we now direct all our cases to an internal email. So that allows us to be able to check for any additional support that the staff teams might need with that case. We review trends and data to help inform learning and training needs. We develop bespoke training. So a recent staff consultation showed the staff were not all confident around the legislation that underpins the criteria for safeguarding inquiries and social care assessments. So our current rollout of training really focuses on that legislation and empowering our teams to be aware of the criteria and how to evidence this. We have safeguarding champions as a point of contact at each service for team members to call on for advice. Those champions are trained to an advanced level. We have an allocated safeguarding lead for the organisation, but also a board member that leads on this piece of work. We complete safeguarding audits and action plans, so we do that at service level, but also as an organisation. And there's actually a free audit assessment that I've used on the Ancraft site that might still be available if people wanted to access it. We also do as much service user promotion as possible, which can be challenging at some services, but we manage to get out surveys, create posters, and really try to understand if our clients feel safe and know how to report. Alongside our training, we also circulate toolkits that help staff with challenges around the criteria and thresholds, evidence in fluctuating capacity, meeting criteria like section 42. And there's some really good ones that we're using at the moment from Homeless Link and the Voices of Stoke. I'm really happy to share those links if that's useful for anyone. We're also closely involved with local MDTs and have a good relationship with partners who can help with any advice. So my final thought really for practitioners working in similar services and also reflecting on Michael's story is that it can feel like quite a challenge and frustrating to get the right support in place for our clients. But trust your own judgment. You know these clients better than anyone else. Create some fantastic networks that can help provide specific advice. We have some great networks with primary health and drug services, and it really is invaluable. And it's really important to make sure your staff teams feel confident in managing these concerns and that they're trained to evidence the criteria needed to progress these cases. So I hope you've been able to take something away from our safeguarding experiences that I've talked about, and I'm really happy to try and answer any questions that you may all have. And thank you for listening to me today.